At that time when I talk about culture, it's what I'm talking about. There's no culture. If you understand how people feel, that's enough. Because of my experience of the patients in Asian community in Boston Chinatown, I was convinced that we need to study culture. That was 1972, I believe. Before I came, when I look at the statistics of mental patients at Tufts New England Medical Center, I was told there is no mental illness in the Chinese community. But when our health center is established, it begin to go outreach, go to the families, the social worker. When I left Tufts 5 years later, I see at least 70 to 80 cases of severe mental illnesses. My activity as a community psychiatrist was very flexible. I do a lot of home visits. So I saw patients at their home. Some of them were chronic schizophrenic, who have been locked up in the residence of their families because they're so ashamed. They did not seek modern psychiatric care, even with the use of psychotropic medicines. I went to Harvard Medical School in community psychiatry. And during my fellowship year, I was recruited by my roommate in Rochester, Dr. Fred Lee, who became a cancer epidemiologist at Harvard. He and I were asked to help the Boston Chinese community to implement program to access health services. So we worked very hard to establish community-based health, neighborhood health center. Fred and I work with community group, and we actually established what is known now as a South Cove Health Center. Now, the whole conceptual framework of that health center was mine, because at Harvard I was I received training in community psychiatry, have a public health approach to things. So I thought the best way to kind of to access health care to the Asian community in Boston was not to build another medical center, because it was in the catchment area where Tufts Medical School is. So the best way, I thought, is to create an intervening neighborhood health center as a bridge between community and the medical center. So with Tufts, with Mass General, with Beth Israel, with all the rest, we don't have to repeat what the major health institutions were doing, but to then the language barrier, the cultural barrier, as well as the economic barrier, because people cannot access health care. We run health screening in the community in Boston Chinatown. So we collected a lot of data, established people with hypertension, diabetes, or tuberculosis, or even some mental problems, but they won't come to us. So the next thing I thought we should do is to address the stigma problem, the issue that confront the Asian community. And the way I did it was to blur the boundaries as patients came to the neighborhood health centers. They didn't know whether they're coming for internal medicine care, or OB/GYN, or anything, or even mental health services. So they don't feel shameful when they come to the neighborhood health centers. During my time in Boston, which is from 69 to then I stay home for 33 years. In the early years of my work, there was no integrated care. There were no community health centers as we are known now. In fact, some of our effort in Boston to establish neighborhood health centers was really a paradigm for other communities. We have to start from scratch to build a neighborhood health centers run by community board with professionals helping out. South Cove Health Center is in existence right now. It is thriving. Albert Jung, for example, is presenting here, is the medical director there. I established that clinic for him, okay? And Arthur Kleinman at Mass General was second-year resident. So he wanted to do research on healthcare in the Chinese community. So Arthur recruited me to help him out in this research project. That's how I got interested in cultural psychiatry. During my time, in this around 70s, at tops I stayed 70 to 75. Culture. If you talk about culture, people laugh at you. When I talk about culture, it's what I'm talking about. There's no culture. In fact, in Boston, there was a very prominent psychoanalyst said that everything can be explained through emotions. If you understand how people feel, that's enough. You don't need to understand culture. So, but I was young. Because of my experience of the patients in Asian community in Boston Chinatown, I was convinced that we need to study culture. But I could not find any references, teaching references. So what I did, I went to NIMH and said, look, I want a grant. I want to submit a grant to pull all the best best psychiatrists, minority psychiatrists, including Gene Spurlock and other people together, and try to see we can develop the curriculum material for culture, to include culture in psychiatry. And I use the minority community, the Asian group, Hispanic, Black, and Native American as a paradigm to look at how cultural issues affect these four groups. Now culture is mainstream in the American psychiatry. Now look at the number of cultural presentations we have had. At my time, 0. Okay. We have to trailblaze to include. In fact, there was no term cross-cultural psychiatry. I was one of the person who pushed for the term of cross-cultural psychiatry to be included among the categories of presentation. So sometimes it's called cultural psychiatry, sometimes it's called cross-cultural psychiatry. That's immaterial, but I'm glad at least we had a lot of people, including young early psychiatrists and residents, who are interested in culture in psychiatry and able to look at that as a legitimate area of professional work, research, and integration into the mainstream nomenclature of DSM.